Indiana Health Information Exchange was one of 17 communities that received the federal Beacon grant. Dr. Snell applied for a portion of that grant to perform a research study around reducing readmission rates. We received around $700,000 for that grant, and with those funds we were able to purchase the technology, equipment, the personnel, and the supplies that we needed to perform the research study. And the study lasted for 2.5 years.
We feel the secret sauce, so to speak, the success factors of our program was really the ability to connect with the patient, even virtually. The very first video conference that the nurse would conduct within 24 hours after discharge from the hospital would be about their medications. She would ask the patient, please bring all of your pill bottles or prescriptions to the device and then hold it up in front of the camera. And the nurse could read it. And then the nurse had the information from the hospital. During the course of the 30 days, the nurse would do, on average, 7 video conferences. And the nurse was also monitoring, of course, every day, the 3 vital signs: weight, blood pressure, and oxygen saturation, and the answer to the 6th question. And the questions were very simple, based on their symptoms, how they felt from one day compared to the next. Well, this proved to be invaluable. Oftentimes, patients with chronic disease have symptoms before you see a change in their vital signs. If the patient didn't do their vital signs or didn't answer the questions, if anything showed up abnormal, then that would create an alert. We made an important decision in early 2012, and that was to open up this study. We wanted to go after the sickest patients we could find, and so we actually recruited them. We found 130 patients, and for those, we monitored them 4 to 6 months, and we had just some amazing case studies.
This one particular patient, we monitored her for a year, and I mean, she literally went from 13 admissions the previous year to 1 the following year. So that's huge.
And her approximate cost was $2,500 compared to $156,000 in 2011. The results of our trial, we had 3 patients out of 75, 4% readmission rate. To be able to lower readmission rate down into the single digits like that, 4%, was truly amazing.
We learned a tremendous amount, and actually very grateful that we were able to have the funds through this grant to be able to trial this program, because without that, we wouldn't be where we are today.
We knew this program would pay for itself in given populations. So we are starting a new program that will launch in the next few months.
And it has 2 patient populations that we're focusing on. We are going to be still focusing on the patients that are going to be discharged from 6 of our St. Vincent hospitals. That's pneumonia, heart failure, and anyone coming out with an acute MI. On the other side, we're going to be enrolling patients that are referred to us through our St. Vincent Medical Group physicians that have complex chronic diseases. And we'll be monitoring those patients roughly about 8 months. We're looking at monitoring 336 patients simultaneously post-discharge. And then on the complex chronic patients, we'll be having 800 at a time simultaneously. When we're full scale, we'll have a staff of about 20. Technology is an important communication tool, and it can make our work more efficient, and we can build in safety measures so that we're providing consistent care across all of our patients regardless of who the particular clinician is for that patient. But the most critical thing is the care model. We'll be monitoring 1,200 patients. These are very unique, specific needs of each one of those patients.